important, most important aspect is vaccine preventable disease and other aspects. So nowadays also, if you find the diphtheria, then you can diagnose it with the classical signs and symptoms, and you can prevent the complication. Okay, so diphtheria is uh, derived from the Greek word, so meaning the leather, and so it is defined by the leather-like membrane which is adherent in the pharynx of the patient. So that is the pseudo membrane. So pseudo membrane means when the membrane is removed, so there is it leaves behind the raw surface with the bleeding. So you have to differentiate from it from the true membrane. Diphtheria, the causative organism, it is caused by the Corneybacterium, and most importantly Corneybacterium Diptheria. Next important cause is Corneybacterium ulcerans, and other species like Hemolyticum and pseudotuberculosis also there. And these are the Corneybacteria are aerobic, non-capsulated, non-spore forming, and non-motile gram-positive bacilli. 4 biotypes of the Corneybacterium diphtheria are known, like mitis, intermedius, bell fanti, and gravis. And among them, the gravis causes the more serious infection, and it is has long history. So it is from the 4th, 5th centuries BC, and there was many epidemics in the 17th, 18th century until World War II. So cases have declined because of the improvement in the hygienic conditions initially, and later on due to the widespread availability of the vaccine, so immunization. Because of these two factors, it's becoming uncommon. So it has the Chinese letter pattern. So the organisms in the staining, it shows Chinese and gram positive bacilli. So pathophysiology, so the diphtheria toxin, the exotoxin, so which is responsible for the symptoms, as well as the necrotic area and pseudomembrane which is present in the mucosa of the affected surface. So because of these two factors, one is the local mechanical obstruction by the membrane, and all otherwise also with the toxin. So toxin which can have local effects. So that is diphtheria toxin, and it doesn't have direct target organ, but complications are there in the heart and nerves in the later on. So first few days of the respiratory tract infection, dense necrotic coagulum of organisms and epithelial cells, fibrins, leukocytes, and all that forms the membrane, grayish-brown membrane adherent, that pseudo membrane. So it's difficult to remove and forms the edematous submucosa. So you have to differentiate from other membranous pharyngitis if it affects the pharynx. Then next step is due to the paralysis of palate hypopharynx is the early local effect of the toxin. And toxin absorption might also cause the necrosis of kidneys, tubules, and sometimes thrombocytopenia and cardiomyopathy and demyelination of the nerves. So these cardiomyopathy and neuropathy, they are present from the 2nd and 3rd week of the illness, and it may be related with the immunological phenomena. So primary focus of infection in diphtheria, so most commonly we'll see in the membrane in the tonsil or pharynx, and it is more than 90% of the cases. So other sites are, the primary is tonsillar or pharyngeal diphtheria. Other sites like nose or sometimes in the larynx are next common. Then there is incubation period of short incubation period, 2 to 4 days, and children younger than 15 years are susceptible to the infections. And there is vaccination, so there may be change in the epidemiology and might affect the older age groups. So pharyngeal or tonsillar. So first, it might just resemble the sore throat, and the fever is there. So up to 102 degree Fahrenheit, and initially there is sore throat and fever, no systemic complications. Then membrane formation is there from 2 to 5 days, and it involves pharynx, so pharyngeal wall, tonsils, fibula, and soft palate. So if the most deadly complications of diphtheria is due to the obstruction of the airway. So there is upper airway obstructions due to the involvement in pharynx, tonsil, but mainly it is in the larynx. So if the membrane extends to larynx and trachea, then it causes stridor and features of upper respiratory obstruction. And along with these infections, if there is enlargement of the lymph nodes in the cervical region and there is edema of the tissue, that gives rise to the classical. So membrane is there in the airway, we can see. Then the membrane can extend in the various area of the upper airway. Then classically, the enlarged lymph node with edema, that will give rise to bull neck appearance. So that will be present. So bull neck appearance is there, stridor is there, and patient is sick looking. So even in the, we have to keep the diphtheria as a differential diagnosis, and patient can have difficulty in swallowing, and then neurological symptoms, paralysis of the palate. So palatal paralysis, bilateral. So then these are the classical symptoms. So then relatively lack of fever, dysphagia, they help to differentiate from the other. We have to differentiate from the Candida albicans infection, abstinence bar virus due to neutropenia or streptococcal sore throat. So other causes of membranous pharyngitis should be in the differential diagnosis. So it will give classical toxic look with the bull neck appearance, and patient neck may be slightly arched back for the air hunger because of difficulty in breathing. So we can see the classical. Then if there is a laryngeal diphtheria, then that presents as the laryngotachybronchitis or croup. So there it resembles that feature. So their hoarseness may progress to loss of voice, and severe respiratory tract obstruction is there, and membrane can be there in larynx. So you can see the membranes is there in the larynx. Then less common, we can have nasal diphtheria other sides. So apart from the most commonly it is in the pharynx and larynx. So then less common is you have nasal diphtheria also there. Then it can just present as a simple upper respiratory tract, means viral upper respiratory tract infection with nasal odor, serosanguinous, purulent, or sometimes erosive rhinitis, and membrane formation is there. Then there is also ulceration in the upper lip, maybe there. So nasal diphtheria. Then cutaneous diphtheria. So it is indolent, non-progressive infection and localized to the area of previous mild trauma, or if there is bruising in the skin, so those areas it is localized to that cutaneous diphtheria, and it is followed by the pain, tenderness, and erythema is there. So and ulcers with sharply defined border and formation of brownish gray membrane is there. So then if cutaneous diphtheria is there, you have to differentiate it from the streptococcal or staphylococcal empyema. And extremities are also affected more often than the trunk. So we can see the ulcerations in the cutaneous diphtheria. Then other sides. So apart from we discuss now, so really it can affect ear as a otitis externa. Then in the eyes, we can present as a purulent or ulcerative conjunctivitis. Then genital tract, it can present as a purulent and ulcerative vulvovaginitis. So in female. So then complications. So what are the important? So complications are very important. So now if initial symptoms are not very severe and if patient does not present in the respiratory distress, then later on you can find cardiac and other. So but most important complications is the respiratory. So primarily it presents with the membrane in the upper respiratory tract. So that can cause upper airway obstruction. And if the membrane extends to the larynx or in the laryngeal diphtheria, then there is stridor and patient can go into the respiratory failure. And if the respiratory obstruction is there, so stridor and retraction is there, patient can go into hypoxia. Or sometimes it can also secondarily due to obstruction and all present as a pneumonia. So respiratory complications are one of the most important. If the patient passes into the next phase after the mild infection, then that time, or if he recovers from the respiratory infection, that time also we might see the cardiac complications. So which are present in the 1 to 2 weeks of the illness following the improvement in the pharyngeal test. Toxicity is there. So because of the late complications of the diphtheria, so cardiac toxicity, it can present as the myocarditis, and myocarditis, so that will be toxic myocarditis. So that can present as the congestive cardiac failure, circulating collapse, or more with the dyspnea and muffled heart sound. So presents as the myocarditis can present as the cardiac failure. So diphtheric myocarditis. Then it can also present with the varying degree of heart block. So atrioventricular block with ST and T changes. Then this arrhythmia. So various degree of arrhythmia, or sometimes endocarditis. So cardiac toxic cardiomyopathy and this cardiac toxicity, that will account for the 10 to 25% of patients with the respiratory diphtheria, and it is responsible for the 50 to 60% of the death. So most importantly, cause of poor prognosis or death in the patient with the diphtheria is primarily due to the respiratory initially, then later on it can be due to the cardiac complication. Then we can see, so if you obtained chest X-ray, so if there is complication as a part of upper airway obstruction and aspiration, so it can present as a pneumonia. So you can see the homogeneous opacity. So there opacity in the right lung field. Or if there is cardiomyopathy, then you can see the cardiac. So shadow will be enlarged. So cardiac silhouette, there will be cardiomegaly. And you can see there is, so these patients, if there is difficulty in the maintaining the airway, so if there is membrane is there and then you suspect diphtheria, so during resuscitations, you have to also keep the ENT surgeon also by the side, because intubations can be very difficult in those cases, because there is the edema and obstruction and membrane formation is there. Or sometimes you might also require the tracheostomy to maintain the airway. So you have to become very careful in the handling. So then next complications. So most importantly, respiratory complications, then cardiovascular complications. Then if in the later weeks. So in second or third weeks after the oropharyngeal inflammation and these symptoms subside, then patient can have neurological symptoms. So one is just acute, means direct toxin that can cause as a palatal paralysis immediately. So then other is late neurology. So you have regurgitation of the fluid or feet, then paralysis of the soft palate and posterior phalange. So that can present as the nasal intonation of the voice and regurgitation. Then oculomotor or ciliary paralysis. So cranial neuropathy. Paralysis of the soft palate, pharynx, then cranial neuropathy also can be there in the neurological toxicity. Then dysfunction of the facial, pharyngeal or laryngeal nerves also may be there. And sometimes it can have peripheral neuritis or peripheral neuropathy that can present as the glove and stalk distribution. So they're involved in the glove and stalking distribution pattern can be observed. And so the neuropathy is eventually resolves. So diphtheria, you have neuropathy which can eventually resolve. Then investigations. So what are the investigations that help to diagnose diphtheria? So classically with the symptoms of the unimmunized or partially immunized child with symptoms of the respiratory symptoms are there, and upper airway obstruction or bull neck appearance and looks, the toxic look is there. Then if you examine, so that time if you suspect it may be the case of diphtheria, then you have to get prepared for the high risk airway management. So with availability of endotracheal tube and tracheostomy sets, and when you do the direct examination of the pharynx or larynx, so that time you can see the classical membrane. So this will diagnose diphtheria, but other investigations also will help us. So in complete blood count, it shows moderate leukocytosis. Then urine analysis that will demonstrate transient proteinuria, and in myocarditis is there, that cardiac marker enzymes may be increased. But most important investigations for the confirmation of diphtheria is so demonstration of the, so that is true for the all the infective etiology. So most important and foremost to diagnose any infection means you have to confirm the isolate the organisms. So direct means you demonstrate in the directly or in the culture, or you demonstrate its antigen or antibody or so like that. So in case of diphtheria, we have the nasopharyngeal, pharyngeal swab for culture, and in the Loeffler's enriched Loeffler's medium or Tinsdale medium, so it can grow. And if it is isolated, then we have to also Corneybacterium Diptheria. So we have various substances there. So gravis, mitis, intermediates. So you have to also differentiate the biotypes. And if you do the gram staining for the diagnosis of the, so from the direct microscopy or in the culture in the enriched media, then it will show the club-shaped, non-capsulated, non-motile bacilli that are found in the clusters, and it resembles the Chinese letter pattern. So then we can diagnose the diphtheria. Then for the toxin or if it is the pathogenic or not, then you have that ELEK test. So or Elix gel precipitation test, so which will diagnose it from the pathogenic to non-pathogenic. So generally, so the bacteriophage is there, so it can cause, if a non-toxigenic diphtheria is there, it comes into contact with the phage with the toxin, then it can also become toxigenic. So direct demonstration or in the culture in the low floor medium and staining, then to demonstrate the toxin. So nowadays it's not really used, but gel test and chest radiograph and soft tissue neck for the airway inflammation and involvement. Then polymerase chain assay to detection for the diphtheria, which is the toxigenic stain. So these are used for the, if we gram staining and culture, so we can demonstrate the organism. Then treatment. So how do you treat case of diphtheria? So most important is, so if immediately after the suspected diagnosis and patient is in distress, okay, so if you suspect diphtheria and patient is toxic and in distress, means you have to stabilize the patient. So airway management, positioning and breathing. So if for airway and breathing, if airway is obstructed, means you might have to place endotracheal tube or tracheostomy. If airway is maintained, and for breathing, and you can give the oxygen. And if it is difficult to swallow and feeding is there, so you can give the IV fluids. So immediate resuscitation, that is first step. Then followed by the, so since it is infection, so and due to the toxic stain, so mainstay of treatment is two things. So specific antitoxin. So diphtheria specific antitoxin, that is the mainstay. And so dose, the mainstay of therapy is administration of the diphtheria antitoxin, and dose and duration that varies upon the site. So, and if antitoxin is not recommended for just asymptomatic carrier, and it should be administered on the basis of diagnosis to neutralize the free toxin. Because if toxin is already absorbed, then it is not effective. So as soon as diagnosis is made, and pharyngeal, laryngeal cases, you administer. So doses means from 20,000 to 40,000 units, so IV over 30 to 60 minutes. And if it is a nasopharyngeal, then a higher 60, and maximum up to 80,000 or 1,20,000 units can be infused, especially in the extensive and laryngeal cases is there. So mainstay of treatment, so supportive treatment. Next is diphtheria antitoxin to neutralize the toxin. Then if asymptomatic carriers are there, then you give the antimicrobial prophylaxis, so which need to be administered for 7 to 10 days. And if it is due to the age appropriate, so in diphtheria toxic exposed and not vaccinated, so they have to also receive the appropriate vaccine. So asymptomatic carrier and supportive treatment. Next treatment is diphtheria antitoxin. Then other important is penicillin. Okay, so pen is antimicrobial agent of choice for treating the diphtheria is penicillin. So penicillin, you can have various preparations, so that crystalline penicillin or penicillin G, that can be administered. Then there is a procaine penicillin also can be administered. So for 14 days. So penicillin G, so 1 lakh to 1.5 lakh unit per kg in divided doses, 6 hourly for 14 days. And in cutaneous diphtheria, shorter duration, 7 to 10 days. And procaine penicillin, 25 to 50,000 units. So important is penicillin. So various preparation, penicillin G or procaine penicillin. And alternative, if patient is allergic or that condition, so if penicillin we have to give for 14 days. If you cannot give penicillin, then alternative treatment can be erythromycin. So erythromycin in the dose of 40 to 50 milligram per kg per day, and that is also for 14 days. That is antimicrobial. Then prognosis. So prognosis of diphtheria depends upon the virulence of the organisms. Then subspecies. So gravis has the highest fatality rate. Then patients age. So age and immunization status. If partially immunized or incompletely immunized, means that can be less severe. And if not immunized at all, means that can present as a site of infection. So laryngeal has the highest mortality, then nasal and cutaneous are relatively good prognosis. Then speed of administration of the antitoxin, means how urgently you have treated with the supportive treatment and antitoxin. Then mechanical obstruction from the laryngeal diphtheria or bull neck obstruction with the airway obstruction. Then or complications, myocarditis, that account for the most important cause of the death. So if patient with the diphtheria dies, so most importantly it is due to the upper airway laryngeal obstruction, especially in the classical bull neck appearance and toxic, or in the just second weeks in unrecognized myocarditis and patient present with the cardiac failure and shock. So that these two can lead to the death. And case fatality for almost 10% for the respiratory tract diphtheria. Means, despite our advancement in the management and ICU facilities and all, so because of these complications, the case fatality is almost 10%. And the most important aspect is diphtheria. So nowadays, and for us, it is among the vaccine preventable disease. So in government of Nepal, in vaccine preventable disease, so that covers around 12 diseases. So you give diphtheria, pertussis, and tetanus DPT vaccine at 6 weeks, 10 weeks, and 14 weeks. That DPT is in the pentavalent form. So it is with Haemophilus influenza B and hepatitis B. And in that schedule, so it is comes as a pentavalent diphtheria, pertussis, and tetanus vaccine, and along with the hepatitis B and Hib. So that is there in national immunization schedule. So you can prevent with the immunization. Then the DT, so diphtheria, pertussis, and tetanus. So if there is capital D, that is coincides with the higher toxoid dose. And if you use in the adolescent or older group, then small d and t is there. So you must have also familiar with the immunization in the pregnant mother. So there you give low dose, or in adolescent and adult, so small d. So that contains the lower dose of the toxoids, and d, small d, and t. So likewise, if you have DPT, so pertussis means capital P is there, so whole cell pertussis. And if it is the small, if it is AP and small p, so acellular pertussis. So that is there. Okay, so then diphtheria. So it is one of the important vaccine preventable disease, and though due to the improvement in the our socio-economic conditions and hygienic condition and immunizations coverage is there. So Nepal almost 70 to 80% vaccination coverage is there. Because of this, all these factors, it's becoming rare. But we have to become very familiar with the this classical symptoms, and if there are outbreaks are there, then we have to recognize and treat. So intermittently, if there is a break in the chain of the immunization chain is broken, so that time there is always the risk. Okay, so in summary, diphtheria means it is caused by the organism Corneybacterium Diptheria. So which is the gram positive organism is there, gram positive bacilli. It can primarily affect the tract. So primary means you have pharyngeal and laryngeal, nasal. Sometimes you can have other sites of involvement like or eyes or ear, that is rare, and genital tract. But primarily is the respiratory, and it causes the symptoms are related with the mechanical obstruction of the airway along with the toxins, and it causes the toxin, and it causes membrane formation in the area of involvement, so in the pharynx or larynx. So it is pseudo membrane, and pseudo membrane has to be differentiated from the true membrane, and it has if there is a pharyngeal diphtheria or tonsillar membrane is there, we have to differentiate from the other similar causes of pharyngitis. So though it's very uncommon, so first you have to keep the pharyngitis is there, means streptococcal sore throat, you have to keep in the first differential diagnosis. Then you have other candidiasis, or if there is immunocompromised patient is there, then absence virus, EBV infection is there. So then a neutropenic patient also. Then in the lower down order, even you also have to keep in the membranes, and this pseudo membrane. So when it remove, it bleeds. Then other is, so it can have respiratory symptoms, upper airway obstruction. Then second and third week you can have cardiac and neurological complications. Then timely recognition and administration of the antitoxin, so it can prevent the complications, and it can improve the outcome. So in the nowadays, if second or third week, if patient even presents with a cardiomyopathy or myocarditis and arrhythmia, so because of advanced treatment facilities, pacemaker implantation and other, so if all recognized, so resuscitation, this can improve the outcome. So